Okay, I think we can go ahead and get started. My name is Mary Jo Fiedler. I'm a medical oncologist at Rush University Medical Center, and I specialize in treating lung cancer patients. I will be starting out moderating the session. Dr. Lipday is in the operating room and will be late to this meeting and may not be able to join us. We'll get everything started. Our faculty for this session is Dr. Philip Bonomi, another thoracic oncologist at Rush, Dr. Christopher Cedar, who is one of our thoracic surgeons. I already introduced myself, and Dr. Marwaha. Garb Marwaha is one of our radiation oncologists who specializes in treating lung cancer patients. So just some housekeeping before we go on. Please make sure you have muted your line so we don't hear the background noises. And please type any questions you have into the chat line. We have plenty of time for questions and answers at the end of the presentation. So please use the chat line for the questions. Just as an introduction, lung cancer, as many of you know, is the most common cancer killer in the United States. We are projected to have almost 230,000 new cases of lung cancer in 2020, and we are projected to have 135,720 deaths also in 2020. But the good news is lung cancer patients are doing better. We have seen a lowering in death rate among lung cancer patients over the years, and this is due to a lot of things. We have multiple new approved treatments. We just had two treatments for lung cancer approved last week rather. We know that lung cancer screening saves lives and detects earlier staged cancers. And we have advanced surgical and radiation techniques that have minimized toxicity and side effects for our patients. Looking at lung cancer and COVID-19, we thought that this was an important topic due to the variety of presentations and complexity of lung cancer cases. It remains a multidisciplinary disease and requires the input of surgeons, medical oncologists, and radiation oncologists to really individualize treatment and improve outcomes. And at this time with COVID-19, it is important to weigh the risk of disease progression against viral exposure to patients. The objectives of this presentation is first to have a comprehensive look at how to navigate lung cancer diagnosis and treatment in the setting of this COVID-19 pandemic. We're going to review cancer center strategies for patient safety that have been taken at Rush. We're going to look at the impact of COVID-19 on lung cancer screening and surgeries. We will review COVID-19 impact on patients with lung cancer, focusing on medical oncology related therapies for lung cancer and also radiation therapies for lung cancer. And then, as I mentioned, we have plenty of time for a question and answer session. So I'd like to introduce our first speaker, Dr. Philip Bonomi. He's our senior thoracic oncologist at Rush University Medical Center. He'll be talking about cancer center strategies for a safe environment during the COVID-19 pandemic. Go ahead, Dr. Bonomi.
Thanks so much, Dr. Fiedler. It's a pleasure to talk about the response that Rush has mounted, not only in treating cancer patients, but in treating all patients. Rush is a leading institution in taking care of people who are infected with the COVID virus. So we had a well-planned out strategy. We redeployed staff to treat patients both in the hospital and in the clinic. We want to minimize risk for our cancer patients and our staff and provide anti-cancer treatment for patients with aggressive cancer. Some patients, as you'll hear later from Dr. Fiedler and Dr. Cedar and Dr. Marwaha, if treatment could be delayed, it was delayed, but we were treating patients that are treating patients who need it. Elective surgeries, not just in cancer, but cancers aren't too many elective surgeries, but elective surgeries are postponed. And Rush, the new tower was configured so they could rapidly expand the number of ICU beds, and they had an ample amount of ventilators, so we were very well prepared for this. And then Rush, and all of us should be doing this, following the guidelines, the national guidelines, social distancing, hand washing, and wear facial masks when you're going to be out and close to other people. Next slide. Be able to advance to the next one. There we go. Oop, let's you go back. I think we go back on there.
Sorry about that.
Yeah, there we go. Yeah. So we had Rush Cancer Center physicians, nurse practitioners, physician assistants, and nurses at our Oak Park and Lisle offices. We elected for this time to close down the cancer treatments and the cancer visits that we had there. So the infusion centers are closed. And Dr. Marlin mentioned the radiation therapy at Oak Park was closed. And these folks were redeployed for critical functions. Some of them, Dr. Fiddler being one of those folks, had 6-day consecutive days stints in the hospital where they would provide care for inpatients with COVID infection. She's done 2 rotations, and many other physicians have stepped up to help the hospitalists and other folks who were delivering inpatient care already. Also, the patients from Lisle and Oak Park, or the nurses, I should say, came to the outpatient infusion center downtown, and then some were deployed to our urgent care center where COVID screening was done. So let me go to the next slide. So the other thing, and trying to reduce risk for patients, their families, and our staff, we tried to convert, and we did convert, many existing and new patient appointments to telemedicine visits. Some we still felt had to come for in-person visits, and they have been doing that. But we wanted to not only do the virtual visits, but we wanted to focus specifically on video visits, and you'll see a slide a little later showing that we have been really considerably increased the number of video visits that we do. And we think that video and telemedicine is going to be something that's going to be increasingly used in the future. In order to do a video visit, individuals have to have a smartphone, they have to have the MyChart app on it, and if that's not feasible, they will have a telephone visit. But we like to see our patients. I think our patients like to see us, and they might want to see me, but whatever. I like to see my patients. And some providers and staff worked remotely. For instance, today I work from home. Next slide. Now, the other thing that we did to reduce the risk of our exposure to the COVID infection, our nurses called patients who were coming in for a clinic visit ahead of time, and they asked them if they had symptoms, and if they did, they were directed to the urgent care clinic, which I had mentioned earlier. There were mild symptoms, they were there, they had a COVID screen, the test for COVID infection. If the symptoms were severe, they were directed to go to the emergency room where they were evaluated and tested for COVID. In addition, all patients who were going to surgery, starting radiation or starting new chemotherapy, were also tested for COVID infection, even if they had no signs or symptoms of that infection. Social distancing, we maintain, keep people 6 feet apart in the clinic. And this is something we wish we didn't have to do, but we have to. And that is when patients come into the clinic, they must come unaccompanied. Their family and friends can't come with them because we're trying to minimize the number of people who could possibly carry the virus or be exposed to the virus. And patients and staff wear masks at all times when they're in the clinic. Next slide. So this is a graph, the bar graph on the right-hand side of that slide. You see the blue bar, especially if you start in the middle of March there on the left-hand side of that graph. You see that the vast majority of patients were coming for in-person visits. Then you see that the blue has really reduced as we move toward the week of May the 4th. And the red in the middle, those are video visits. They have really dramatically increased over that time. And this has worked out really quite well. And, we are able to see our patients, which is something we think is important. We have maintained the volume of patients coming into our outpatient cancer center at an 80% level. 20%, we said, your visit could be deferred. You could come in a month or come in 6 weeks. But 80% of the patients who had visits were seen either virtually or in person. And about 80% of the patients who are on infusions continue to get their treatment. Dr. Fiddler will talk about some of the strategies that she has used in the lung cancer patients to reduce the number of people coming in for infusions if it wasn't entirely necessary. Now, then the left-hand side there is kind of small, but I want to point out that with the screening techniques that we've done and the very careful screening, not only with a test, but with phone calls and talking to patients, we have really minimized the number of people who've had COVID infection. Our staff, if we look at the entire outpatient staff in the cancer center, the rate of infection is less than 1%. If we look at all the visits to patients that came into the clinic to see a physician, a nurse practitioner, to get infusion, to get radiation therapy, or for scans, and we did minimize those to some extent, less than 1% actually had COVID infection. And all but a couple of those were found before they actually got into the clinic. So pre-screening, got an actual screening with a test if they needed it, and less than 1%. We had one patient that came into the medical oncology clinic who had said she had no symptoms, but in fact that wasn't quite the case. And when the nurses saw she had symptoms, they tested her and they found that she had COVID and she was then isolated. And Dr. Marwah will tell you about a patient who got successfully treated with radiation who had infection with the COVID virus in his presentation. Next slide. So we've continued to provide in-person and virtual visits. We're increasing the number of in-person visits now and increasing the number of treatments. All new patients now, previously we were offering video visits to many of them. Now we're offering in-person visits for all. For patients who feel uncomfortable coming in, but as you can see, it's quite safe, they would be offered a video visit. And the risk of contracting COVID infection at the Rush Cancer Center outpatient is extremely low for not only patients, but also for staff. Thanks very much. And I'd like now to introduce Dr. Chris Cedar, who's an associate professor of thoracic surgery at Rush, and he's going to talk about how the surgical team has approached the management of the patients during the COVID era.
Thanks so much, Dr. Bonomi. I'm going to go through with everyone what we're doing from a surgical standpoint to make sure that we keep our patients and our healthcare providers safe. There are a number of guidelines that have been released from surgical societies, including the Society of Thoracic Surgeons, as well as the American College of Surgeons, to help direct hospitals and direct providers in these unprecedented times. Rush has taken many of these recommendations into account about who should get surgery, when should they get surgery, and the best way to ensure the safety of everyone involved. Being one of the leaders in COVID care in the Chicagoland area here, I'm going to explain to you guys what exactly we're doing. And you have to remember, this is all changing on a day-to-day basis as we learn more. Next slide, please. So at Rush, as a whole, we're taking a number of precautions to ensure everyone's safety. This includes universal masking in our hospitals and ambulatory facilities. Complimentary masks are handed out to everyone who enters the hospital. In addition, prior to entering the hospital, every person gets their temperature checked and they're screened for symptoms that could suggest a COVID infection. Those exhibiting symptoms or who have a fever are triaged for care or asked to return home. Our environmental services team continues to work hard, performing rigorous cleaning of all facilities, especially the high-touch areas throughout the hospital. Hand sanitizer dispensers remain available throughout the hospital. And for everyone's safety, as Dr. Bonomi began to mention, we require at least 6 feet between people unless receiving direct patient care. There's modified seating arrangements now in all of our waiting rooms and all the common areas, so that all the seating is 6 feet apart. And finally, we continue to restrict visitors in all inpatient and outpatient facilities, except in very specific cases. Next slide, please.
Sorry, okay.
And, one of the biggest questions that we get is, who are we operating on? Who should we be operating on this time as we weigh the risks of bringing a person into the hospital for surgery versus letting them go without surgery. And although hospital resources are more limited during this time, we know that certain patients just can't wait and need to get into surgery sooner than later. And waiting until the pandemic's over for a number of months potentially would be detrimental to their overall survivorship. So from mid-March up until now, we've continued to operate on all cancer patients who we did not believe should wait 3 months or more. And that includes most lung cancers. There are a few indolent lung cancers or less aggressive lung cancers, such as carcinoid tumors or maybe non-solid tumors that we're deferring off until after the pandemic starts to cool down. In addition, patients with benign disease who require surgery are being delayed at the current moment. And along those lines, patients who would normally come in for lung cancer screening, those patients are being deferred. And so there's more of a delay there than we normally would have, but that's all to keep our patients safe. Next slide, please. So outside of the general precautions that the hospital is taking, there are some surgery-specific precautions that Rush has instituted, and that starts in the clinic. Virtual visits are encouraged. That's all both through telemedicine visits as well as video visits. And when you do actually come into the hospital, our appointments are spaced out at greater intervals than they normally would be to maximize social distancing. Anyone who's scheduled for surgery is required to get a COVID test within 24 hours prior to coming in, okay? If they're COVID negative, they come into the hospital and their entire pathway is in no contact with COVID patients. What that means is they get a mask when they show up in the hospital. They have physical separation throughout their stay. They will not be in the preoperative area with COVID patients, postoperative area, or the wards. They are all completely separate. And even to the point where we have certain operating rooms that we do surgeries on COVID patients, and the remainder of the operating rooms are non-COVID rooms. So if you don't have coronavirus when you show up, you will go down the non-COVID pathway. So I hope that this reassures you that we remain dedicated to cancer care. We are continuing to operate on lung cancer, and we're doing everything in our power in these unprecedented times to make sure that both our patients as well as our healthcare providers remain safe. Next slide, please. I'm going to now reintroduce Dr. Mary Jo Fidler, who's an associate professor of medicine in medical oncology, to talk about the medical oncology aspects of what we're doing here.
Thanks again to everyone joining us. I'm going to talk about a couple things. The first part of the talk is talking about cancer in general, complications from COVID-19, and then more specific to lung cancer patients and COVID-19. So I'll start with the cancer and complications from COVID-19. So most of the published data come from China, where the COVID pandemic hit or before. And what we know from relatively small studies in a relatively short time is that there is a higher risk of complications, it seems, for COVID-19 in cancer patients. The severity of complications also appears to be increased. So if a patient has a complication from COVID-19, it's more likely to be a more severe one. There's a higher frequency of patients requiring mechanical intubation on ventilators if they have cancer and COVID-19. And it's unclear, but the incident rate may be a little bit higher in cancer patients, although there's clearly bias in who's coming in more often to the medical centers to get testing. And at least in the United States, the testing procedures and policies have been changing as we have more and more ability to test patients. So far, we don't have any proof for sure that lung cancer patients would have an increased incidence. This was a study I wanted to go through in a little more detail, as it has a larger number of cancer and non-cancer patients to compare. It was a cohort study of 105 cancer patients and 536 non-cancer patients with confirmed COVID-19 that were hospitalized in Hubei province, which is where the COVID-19 was first detected. They found that hematologic patients, so leukemias, lymphomas, hematologic cancer patients, lung cancer patients, and metastatic or stage 4 cancer patients had the highest frequency of severe complications. Their cancer patients of this cohort had higher in-hospital infections. They also had a higher smoking history, and they had difficulty breathing as a more common presenting symptom. They also did have a higher rate of death and critical symptoms needing ventilation. More specifically, with lung cancer and COVID-19, we're gaining more and more information about this, and Russia's proud to be part of the Teravold study, which is a multi-international effort to capture information about lung cancer patients who became infected or had highly suspicious symptoms for COVID-19. So we do have information on the first 200 patients entered this registry study. The caveat is most of the entry was from Europe, particularly Italy, whereas you may have heard on the news, they did have difficulty with the amount of patients and the volume in hospitals with not as many resources as they would have liked to treat their infected patients. So the median age of the 200 patients was 68. 81% were current or former, had a history of smoking before. And the stage breakdown, and again, these are all lung cancer patients. A small percentage was early stage, stage 1 and 2 was 8.5%. 18% was stage 3, locally advanced lung cancer. And 75% of the patients had metastatic or stage 4 cancer at the time of their COVID diagnosis. The vast majority of patients had other comorbidities, meaning diabetes or hypertension or vascular problems, perhaps chronic obstructive pulmonary disease, COPD, and more than a quarter of patients had at least 3 comorbidities along with their COVID-19 and the lung cancer. Of those 200 patients, 76% required hospitalization, and I think this is an interesting point. The treatment breakdown for the patients who were hospitalized, a little more than a quarter of patients were on tyrosine kinase inhibitors, or written here TKIs. Those would be the drugs specific for lung cancer patients who have been found to have driver mutations, so EGFR, ALK, ROS1, those you may have heard of. And then the majority of patients were either on immunotherapy or chemotherapy and immunotherapy, and then some of the patients had other treatments in addition to these. They did find that the treatment that these patients were on, of these first 200 patients, was not associated with an increased risk of death or hospitalization. So they did not see an increase in hospitalization or death if patients were on a tyrosine kinase inhibitor versus chemotherapy versus immunotherapy. The most common symptoms these patients had upon presentation overlap with lung cancer symptoms, and they were fever, cough, shortness of breath, and fatigue. As I mentioned, many of the patients in this study came from Italy, where mechanical ventilation at the time of this crisis was only allowed in about 2.5% of patients. The complications that developed, the vast majority had further respiratory complications, so inflammation of the lungs or pneumonia. About a quarter of patients had severe respiratory problems, and then a smaller percentage had other organ systems which failed or severe infections. I do want to just highlight that, these symptoms were quite advanced. I mentioned there was a bit of rationing of care due to resources. But the exciting thing is that this Teravold study is a huge international effort with over 21 countries and a great way to move forward. Not only are they studying how patients presented with COVID-19 and lung cancer, we're also going to be looking at down the road, are there more complications for patients who may have recovered for the next treatment they have for their lung cancer, whether it be chemotherapy or immunotherapy? There's a lot of data to be learned, and I think as we have more patients entered from different parts of the world and from the US, I think we'll see some of the severe complications hopefully decrease. Now, more specific to lung medical oncology during COVID-19, the risk of COVID-19 should be balanced against a risk of lung cancer progression and complications from a lung cancer diagnosis. Shared decision-making is recommended, and that's where a patient and a physician come together, reviewing the treatment options and the pros and cons of the various strategies to make a decision. At Rush, we have tumor board meetings that have been continuing in a virtual format. So we have a multidisciplinary clinic that is discussing plans for new patients or patients returning with new problems involving radiation oncology, thoracic surgery, medical oncology. We have radiology present and pathology present. And it's a weekly meeting that we've been able to maintain for our patients. The next few slides go through different priorities we've taken for our patients, and these are not in order of importance, but I just wanted to go through some of the things we've been thinking about as we see lung cancer patients in this COVID-19 pandemic era. And the first priority is to make sure patients are appropriately tested for driver mutations and molecular markers. With the most common kind of lung cancer, it's our obligation to look for a driver mutation that we can use pills for and potentially avoid visits to the clinic for chemotherapies or immunotherapies. Some companies with these assays have home phlebotomy as an option for patients. And this is very important. As I mentioned, lung cancer treatment at the beginning of the talk is getting better. Just last week, we had 2 new FDA approvals for driver mutations that we need to be testing for. Patients should have their PD-L1 status checked. And this is particularly important because now one of the most common drugs we use for immunotherapy based on PD-L1 testing can be given every 6 weeks now. So that is a way to reduce touch times for patients to the medical center. And for select patients who have an intermediate level of expression of the immunotherapy proteins, it could be a good option to give patients immunotherapy alone in the setting based on comorbidities and risk of infection, and of course, in a shared decision-making manner. Priority B involves controlling symptoms. As Dr. Cedar would attest to, we are treating patients who have fluid buildup in their lungs aggressively. We're treating brain metastases aggressively. And we're also initiating necessary management for those who need it, whether it be chemotherapy, immunotherapy, combination chemotherapy, immunotherapy, or those targeted agents that we try to use for patients with driver mutations. Priority C is delaying or stopping treatments. So we've been discussing a delay in treatments for patients who are what we call in a maintenance phase, meaning their cancer has been under good control for at least 6 months, and they have been on medicines usually at a 3 or 4 week interval that is designed to keep the cancer under control. We have been discussing delaying treatments for some patients who may be particularly higher risk for COVID-19 complications. We also are deferring clinical trial visits for non-essential activities and treatments not thought to be important for patient safety. The good news we have to report as of this week is that our clinical trials are reopening. So starting May 18th, we'll be able to accrue to our clinical trials again, which is a great option for our patients. And the last bullet point with priority C is that we are discussing stopping immunotherapy for those who have been on treatment for more than 2 years. Most of us do try to reach that 2-year mark on immunotherapy if we can, but there is some debate on how long it should be continued. So I've been offering discontinuation for patients who have been stable on their immune system-based therapies for longer than 2 years. And priority D would be to delay some supportive therapy unless it's being used to control calcium levels, bone supportive therapy in particular, like denosumab or zoledronic acid. And also for patients who have metastatic cancer, if they are quite stable, then there may be times when we all feel comfortable spacing out their routine follow-up restaging studies to minimize touches to the medical system. I think when the pandemic started, we were all hoping we'd have a relatively quick reopening, but we will be thinking about all these priorities probably for the next number of months. With that, I'd like to introduce Dr. Gaurav Marwaha. He's an assistant professor in the Department of Radiation Oncology. He's the residency program director, and he's a specialist in thoracic cancer.
Thank you very much, Dr. Fidler, for the introduction, and thanks to all our attendees that are tuned in tonight to learn about our efforts here at Rush to take care of our lung cancer patients during this pandemic. Just a quick overview about radiation therapy. It is a common, safe, and effective cancer treatment. 2/3 of all of our cancer patients receive some sort of radiation therapy over the course of their disease management. We use high energy radiation beams to kill cancer cells in a painless fashion, and primarily this is by X-ray therapy. We've had a lot of advancements recently with both imaging technology as well as treatment delivery platforms that has enabled us to treat sometimes even very large tumors with very minimal side effects, as we're able to protect better the healthy, normal parts of a patient's anatomy. Radiation is a vital component for lung cancer treatment, both for small cell and non-small cell lung cancer. There's various indications that could be curative in nature, sometimes by itself, sometimes with chemotherapy. Also used after lung surgery based on certain indications, as well as usages in stage 4 diagnoses. Oftentimes these are either palliative in nature to help relieve some of the symptom burden associated with the cancer. Pain, for instance, is one of the indications for radiation, as well as an expanding use of radiation for the treatment of oligometastasis, which is really just a fancy word for patients who may have a limited number of sites of metastatic cancer coming from their primary lung tumor. Radiation classically is delivered through a mechanism called external beam, and that really is just the traditional form of radiation therapy that's given over weeks generally. And then there's also radiosurgery, which has acronyms like SBRT or SABR, standing for stereotactic body radiation therapy, or SABR, stereotactic ablative radiation therapy. And these treatments can be delivered in as few as one treatment, depending on if the patient is a candidate to receive it. The next slide, please. So what have we done here at Rush during the COVID-19 era? We have sustained all of our operations. We're taking care of pretty much any lung cancer patient that meets the criteria for treatment. Really the key here, and this is a strategy that we as a team employ at Rush even before the pandemic, but it's a personalized treatment strategy. It's patient-centered. There's shared decision-making with contribution from all the members of our team, many of whom are on the call alongside me as a panelist tonight. And we do balance the risks of the patient's cancer, what the treatment course may look like, if it's, for instance, several weeks of radiation, the back and forth coming in and out of the cancer center. We do take that into account in and around this the COVID era. But there are times that we've been able to very successfully, in just a single treatment or sometimes a couple treatments, eradicate lung cancers, and we're doing that more frequently during this time period. We do otherwise follow all national recommendations for safety and quality, and as many of you are probably aware, Rush is a leader in these domains, and part of that is maintaining a safe environment for all of our patients and all of our staff. We do have in-person and video visits. We have certainly accommodated as many patients as we can in person, but there are situations that have been discussed by the other panelists that are maybe more routine surveillance patients that can be safely seen over a video consult. Next slide, please. In terms of patient safety, we do screen every single person that comes in and out of our center. We're on the first floor, so it's a kind of an easy access point, but we do have a dedicated team that screens our patients. We have aggressive testing procedures, so every single patient that's coming in for potential radiation is being tested ahead of time for the virus, and these tests are conducted not only here at our main site downtown, but also at some of our satellite locations through driving clinics and so forth. Our nurses have been phenomenal at coordinating these efforts and making sure that everyone is being screened before they come to see us here in radiation therapy. There's comprehensive cleaning and sanitation procedures. Specifically, if we are treating somebody who has the virus, they're treated at the end of the day and in a specific treatment machine and a unit that is thoroughly cleaned per our quality and safety protocols that exist. And then, we really haven't had any issues in terms of personal protective equipment. There's adequate gowns, gloves, and masks for both patients and staff members alike. The next slide, please. So we recently completed a course of radiation therapy, a 6-week, which is a definitive or a curative dose of radiation for a patient with locally advanced non-small cell lung cancer who initially started off not having any signs or symptoms of COVID-19, but did develop the infection along the way. He was living in a nursing facility, acquired the infection there. We were able to accommodate him here at Rush and keep him in our hospital safely for the duration of pretty much the last 2/3 of his radiation therapy. By the end of the treatment course, he had recovered from the virus and had tested negative for it 2 separate times, and had also, as this picture shows, completed with a certificate in hand the course of radiation. No one else was infected throughout this gentleman's treatment course, inclusive of other patients that we treat as well as our own staff. And that speaks to the quality and safety of the Rush operations. In summary, it takes a village, a lot of us kind of working hand in hand, doctors, nurses, social workers, inpatient, outpatient, providers from other specialties to make sure that we can take care of every patient as a team.
Oops, excuse me. So we have time for questions, and I'm going to turn it over to Dr. Cedar, who's going to moderate the question and answer session. There should be a chat function that you see on the WebEx. Before we go, I just would like to thank the Rush Cancer Center leadership, in particular Mary Ellen Hand, who is a former thoracic nurse navigator at Rush and has met many of our patients and helped them along the way. And Lakshmi Venugopal from the Medical Education Office, who really went out of their way to help get this program together. And thank you to all the participants who have called in, and we look forward to hearing your questions. So I'll send it back to Dr. Cedar.
All right, thanks so much, Dr. Fidler. So yeah, I'd encourage everyone to please send in any questions that you have right now. We can see them. We have one comment here that said that having recently had a family member diagnosed with non-small cell lung cancer during COVID, I was blown away by every inch of the hospital and cancer care team. Amazing quality, care, and compassion. Thank you for your expertise and sharing your insights tonight. Well, thank you for trusting us with your loved one. It's it's an honor, and we'll continue to do the best we can. Another question we've got here. I suppose I'll answer this one since it appears to be a surgically related question. But what can we do for a new patient who's about to have surgery to support them after their surgery? And so I'll tell you, every patient that has surgery is a standard part of their protocol. Before they leave the hospital, they're evaluated by social work, they're evaluated by physical therapy, they're evaluated by occupational therapy as needed. And whatever additional needs, speech therapy, whatever additional needs they may have as they leave the hospital, we take into consideration, and we make sure that you have the appropriate aftercare arranged. Even if that means going to a short-term rehabilitation center. Really, with the COVID pandemic, the burden on family members as a patient leaves the hospital should not change compared to what it was beforehand. The main change, and I don't minimize it at all, is the fact that our patients can't have visitors while they're there in the hospital. And And that's a tough time for everybody. And, family members and friends really help that process along. So we're looking forward to being able to get everybody back into the hospital. Let's see here. Going back, Jill Feldman, one of our longtime supporters. She asked, as society begins to open up, what are your recommendations for your patients in terms of re-entering as well? Dr. Bonomi or Dr. Fidler, would you like to address that?
Mary Jo, please.
Okay. Well, it's a tough question. As we discussed, there is a bit of increased risk of complications being exposed to COVID-19. There isn't overwhelming data to suggest that a patient with lung cancer would be much more likely to get COVID-19. So I think following the precautions as best as we can, it's going to be a balance of, living life and taking precautions and, managing risk. Dr. Bonomi, what do you think?
I would just add to that as you mentioned earlier, we don't know many things related to this virus, but what I believe is somebody with lung cancer who has early stage and doesn't have significant other comorbidities like bad emphysema, or even somebody with advanced disease is in remission, I don't think they're at risk for a higher chance of getting the virus, and I believe they're also probably not at risk for having worse outcomes if they get the virus. Now, if somebody's got progressive disease, they're weakened, that person is at increased risk. There's no question about it. But folks who are not having those symptoms, I believe, we don't know this for sure, but the stuff you talked about, the terrible study, is going to shed some light on that. I believe they're going to be fine.
I think what supports is that the preliminary information we have is that the treatment that patients were on did not affect their complications so much. And we talked about those slides already earlier in the presentation, but if you may remember that over about 80% of patients had many comorbidities were included in this registry. And those were the ones who had presented to the medical center. So I think it's a risk and a balance, but I agree with what Dr. Bonomi had mentioned as well.
All right, thank you. Another question that we have is, can COVID patients who also have lung cancer still get surgery if the surgery is imminent? Well, as a surgeon, my number one job is to make sure that the patient has a safe process throughout their care, including the operation itself. If a patient was known to be COVID positive, almost certainly, and of course we take it by a case-by-case basis, but almost certainly we would wait for that person to recover from their COVID infection, test negative, and then proceed with surgeries. There's very few cancers that can't wait a few weeks while the patient recovers from COVID. Now, that doesn't mean that COVID patients cannot go to surgery because we have COVID-specific operating rooms, but those operating rooms are generally filled with patients who have complications related to their COVID or emergencies, things like appendicitis, something that can't wait a few weeks. So if you have a lung cancer and you currently have COVID, we will get you into the operating room, but it would likely be after you've tested negative. So here's a question. My mom is scheduled for surgery this Friday, and this is directed towards Dr. Fidler. She has not been tested for the COVID-19. No one's asked her to come in yet. Should we come in as soon as possible? If you don't mind, maybe I'll just go ahead and take a stab at this one. So what I'd recommend here is you will need to be tested, and I suspect that our office staff is in the process of reaching out to you in order to in order to arrange this. Now, if somehow we've had a few patients who were unable to leave their house to go get testing in the 24 hours prior, we do have rapid on-site testing. So that means in the preoperative area, if you came in, you'd be tested for symptoms and for fever. If you did not have that, you would still undergo the rapid on-site testing in the preoperative area to ensure you don't have COVID, and then your care would go on from there. But if you do not hear from anybody by tomorrow, I'd recommend calling our office, and we'll ensure that this gets taken care of. All right, next question. If a patient suspects they have COVID-19, what do you recommend they do? Should they call you first? Dr. Marwaha, have you had any, do you have a, would you like to address that?
Absolutely. You know, if a patient suspects that they have the infection, giving us a call is a very quick first step to either get one of our nurses or doctors on the line. Typically, you know, in this situation, we have through our virtual platform a way for patients to express, even through just clicking a few buttons on their app, for instance, what their symptoms are, and that'll pretty quickly connect them with a physician or a physician extender on the other end to do a thorough assessment as to whether this patient, you know, needs to get tested sooner than later, or if there's significant enough symptoms to warrant an emergency room visit. But definitely a good first step is if you're planning to come in to just call, you know, the office of the team you're going to see, and then we can help navigate the next step. For those that already are plugged in through the Rush the MyChart and the app, there's actually a very seamless way to share your symptoms virtually and get connected through telehealth with somebody very quickly to help assess your risks.
The other thing, this is Mary Jo Fiddler. The other thing I would add is that the Rush Cancer Center, we do have an urgent care clinic, and if you call the Cancer One line and get directed to the urgent care clinic, they will call you. When you come to the medical center, you know, they'll make sure you have a mask and escort you to get the testing in a safe place, and can order any radiology studies that may help, can give you some fluids and supportive care. So the urgent care has been a gateway for our patients who have been tested for the virus, and many of them who do test and have been found to have COVID-19 have been able to go home from there. But I agree, a phone call is a great way to start. And if you Google, and I just did, the Rush COVID hotline, we have a hotline. It's 1-888-352-7874, which is open Monday through Friday, and that's for any existing patients or patients, or people don't have to be patients at Rush at all. It's that same telemedicine. Well, they'll get screened and advised to do as far as pursuing testing and clinical care.
All right. Thank you. We have another question. A patient had 2 large tubulovillous adenomas removed 6 months ago. Should they keep their appointment for a colonoscopy coming up next week? And you know, to address that, I'd say contact your gastroenterologist and ask them that question. It depends on what was found on the initial colonoscopy, and also they'll know, you know, which patients they should bring in and which patients they shouldn't. So it's hard to say as a general rule, but you know, if colonoscopies are occurring, then the team and the gastroenterologists believe it's safe and in your best interest. Okay, so here's another question. What about those of us with stage 4 lung cancer and kids returning to school in the fall? What kind of recommendations do we have? Should we keep them home? Dr. Fiddler, Dr. Bonomi, would you like to address that?
Yeah, I'll make a comment about it. I think, first of all, we have to wait to see if schools are going to open in the fall. But assuming that they will, I believe, you know, go to school and then just follow all the things we've talked about now, which are good frequent hand washing, being careful. Any symptoms, call your doctor and report it, get tested. Who knows that, you know, they're increasing testing so much, will they test kids when they're going back to school? There's been the initial impression was children not going to have so much problem with the coronavirus, but we know now that's not true. They do have a problem, not as much as elderly people, not even close, they can get this virus. There now is a syndrome that is similar to another type of like autoimmune illness that we see in kids called Kawasaki disease, and that's starting to be seen. And hey, for those of you, and I'm a big admirer of Dr. Fauci and the advice he's been giving, he keeps saying, and Dr. Fiddler said this too, we don't know a lot about this virus yet, so we have to be very careful, and we have to be very observant. We have to learn from what we see, and that will help us to be safe. And hopefully, eventually, we'll have a vaccine, or in addition to that, treatments that actually can treat the virus. So, but I'd say if school opens, it's okay to go. You just have to be, careful and alert if you have symptoms or anybody in your family does, and you need to call your oncologist or your primary care doctor for the other members of your family.
Thanks, Dr. Bonomi. We have another question here. Are you continuing to do lung cancer screening? I mentioned before there's a little bit delayed there, but Dr. Fiddler, what's that?
So the current guidelines for most of the specialty societies is halted temporarily lung cancer screening. And if a patient has a known area on their CAT scan that they've had a screening test already and need certain follow-up, that isn't necessarily being delayed. But if a patient has a smoking risk and does not have any symptoms related to lung cancer, no shortness of breath or weight loss or any other symptoms, then the current recommendation is to delay the initiation of lung cancer screening. It may be, and that's the current recommendation. Right now, some places are starting to open back up. For example, we're doing more elective surgeries now at Rush. So I'm hoping that lung cancer screening will open back up soon. Dr. Cedar, have you heard any dates for that yet?
I haven't heard any specific dates as far as when it will open up. I don't know. Okay, so here's another question. I read about COVID patients having micro blood clots in their lungs, heart, and other organs. Have you encountered any such patients with this sort of clotting, and how would it affect their cancer treatment? Dr. Marwaha, a lot of what you do involves imaging of patients. Have you seen that?
In my personal experience, no. I think to reiterate what Dr. Bonomi has said, and what we hear from Dr. Fauci as well, is there's so much that we just don't fully understand about this virus. We were able to successfully treat somebody who otherwise had some pretty high risk features that we would have expected complications from his virus, but we didn't see anything on day-to-day setup imaging, which is what you're referring to, which is the films that we use to make sure our radiation patients are perfectly aligned for their radiation treatment day in and day out. There have been reports of people finding things on these images. I personally haven't seen any of that as of yet, even in some of our higher risk patients. However, there are reports that these things are happening, and I'd say certainly that the most important thing is to make sure that the patient is otherwise stable and healthy enough to receive cancer therapies. So kind of figuring out what exactly the nature of the clot is and how that's affecting the patient. These patients will oftentimes require therapies to break up the clot before reinitiating cancer therapies. But fortunately, in our practice as of now, we have not seen such an event.
We have had patients in the hospital though with those problems with the blood clotting, and there have been a couple webinars done by our hematologist on that subject too. I just wanted to add for the lung cancer screening, Mary Ellen from the Cancer Center has mentioned that lung cancer screening right now is projected to open back up June 1st. And the other thing is that I mentioned that we have the COVID hotline, which is 888-352-RUSH. If you did call that and were recommended to have a test, Rush does have drive-through testing available at Rush Downtown, Rush Oak Park, and Oak Brook already set up, and those tests can be ordered by whoever you're talking with on the hotline.
And that begins to address when would you recommend us going to the ER when would you recommend a patient, Dr. Fiddler, going to the ER if they suspect that they may have a COVID infection?
We'd encourage people, if they have mild symptoms, so a little bit of shortness of breath or a little bit of a cough or a fever, perhaps, to seek care in our urgent care center and be triaged that way. But if someone is having shortness of breath, a bad fever they can't get down, is feeling very sick and not stable, then the emergency room is the best place. And they also have procedures down there with to keep people separated, and have done a great job of taking care of our patients.
All right, very good. And it looks like we do have one more question here. And I don't know the answer to this. Anybody please chime in if you know. But what are the names of the new FDA approved drugs for COVID?
Remdesivir, which is an antiviral, has been approved. I'm not aware that other drugs are approved. Anyone else?
No.
I want to, we've had various comments about trying different remedies, and I caution people from not to try things. There's early on, hydroxychloroquine, it was touted as possibly being good, and it still might be. We still have studies going on with that, but someone in Arizona, a husband and wife, they decided to take a chemical that they used to clean their fish bowls, and because it had hydroxychloroquine in it, and they both died. So we have to be very careful with trying things. There's a lot of stuff out there on the web that is not good. So we have to be careful. And any of these things, if you have symptoms, if you have a concern, call your doctor. Call and talk to your doctor. And I also say, don't just go to the emergency room, because as Mary Jo's pointed out, call, because when you come, especially come to the urgent care clinic, you're actually met at the door by somebody, and they escort you and keep you isolated in case you do have COVID. So you call first and then come in and be checked.
All right, Mary Ellen Hand, one of our nurse extraordinaires here at Rush, just said that drug is being used here at Rush on clinical trial as well.
It's another thing Dr. Fauci has said repeatedly, and other medical experts on the various news programs which are on almost constantly, that you have to have clinical trials, and they start out, they're phase 2. Is there some hint of a signal? Does it look like it's working? Then they would move on to phase 3, and you really need a phase 3 trial to prove that something is effective. Remdesivir, it reduced the duration of the symptoms. That was significant. Different, so that was good. That's how it got approved. And there was a trend for longer survival, or a higher survival rate. But that needs more time, more study to see if, in fact, in larger groups of patients, what we hope we see is it reduces the death rate.
Well, not having any additional questions here, I do appreciate everybody logging in. I appreciate our panelists. I think this is a good session, and I hope that this gives everyone a little bit more confidence that we're doing everything we can here at Rush to make sure that not only our patients, but our healthcare workers also stay safe, and we're continuing to fight cancer here. That's what we do, and we're dedicated to the cause, even though we're in kind of different times now. Dr. Bonomi, any final words?
Well, just thank you to everyone for signing into this. We hope that you got some useful information, and we're available. If you have questions or comments, you can call us, and you can call the Cancer One line, and they'll get you to us, and we'll be happy to talk with you.
Oh, you know what? Last minute question. Are there any supplements that may help me keep the virus away? I'm unaware of any myself. Anyone else?
I'm not aware of any, Mary Jo or Gaurav.
Not that I've heard of.
No.
No.
Okay.
You know, there are many things that are touted for stimulating the immune system, and really pretty much none of these are validated. I do believe the following thing: get adequate rest, practice social distancing, wear a mask when you go out, eat a healthy diet, and stay active. You know, you can go out, you walk. Doesn't have to be, super strenuous, but just maintain your activity level, because as we are being asked to stay in and we're doing that, it's easy to be a couch potato. Don't be a couch potato. Keep moving, eat healthily, and follow the social distancing guidelines.
The other thing we have is there's a couple of other things that I can say about that is one, we do have cancer center dietitians that are available to do virtual visits or potentially in-person visits that could talk to you about nutrition and potential vitamins. And the other thing is that there's a good resource I've sent patients to before, and it's Memorial Sloan Kettering Cancer Center. They have a herbs and supplements database that I haven't checked it recently, but in general, they've tried to keep up to date, and it's a nice central place to get knowledge and review what information there is out there for the various herbs and supplements.
We have another question here. How much personal protective equipment do I need to come into the clinic? And really the answer is just a mask. We provide a mask when you enter Rush, either here or at Oak Park or at Lisle or Oak Brook. A mask is provided. Of the most important thing is good hand sanitation. So washing your hands, being careful what you touch, don't touch your face. Some people choose to wear gloves. If you do that, don't use the gloves to then touch your face. There's not any other personal protective equipment that is required. Okay. All right. Does anybody, without any other questions, I think we are all set. And all of these do apply to Lisle as well. Well, thanks so much, everybody. And we appreciate you coming on, and stay safe out there.